Good afternoon, everyone. Actually, good morning, everyone. My name is Morgan Gargiulo from the New England QIN-QIO, and I will be your moderator for today's webinar, MIPS Quality Performance Category Demystifying Scoring. Before we get started, I wanted to go over a few housekeeping items. This call will be recorded for training purposes, and I'll provide you with details on accessing the recording at the end of the webinar. As you heard, the phone lines have been placed on mute for the duration of the presentation. We will be allowing people to ask questions at the end of the presentation, and we'll give you instructions on how to do that at that time. If you do have a question during the presentation, you can enter it in the chat box at the bottom right corner of your screen. But please make sure to send all questions to all participants so that we can keep up with the incoming questions. And then if you haven't yet downloaded the slides for today's presentation, I'm going to place a link in the chat box where you can get the slides. So with that, I will pass it over to Leela to get us started.
Great. Thanks, Morgan. Hello, everyone. Welcome to MIPS Quality Performance Category Demystifying Scoring through benchmarks, deciles, and measure selection. My name is Leela Valinsky. I'm a Senior Program Administrator and the Regional Lead for the Quality Payment Program work at Health-Centric Advisors, the New England Quality Innovation Network Quality Improvement Organization. Just a quick disclaimer, all of these slides were created by me based on CMS content, so if there's any errors, I apologize, and we will get you corrected content once we send them out after the presentation. So, quick overview today is completely focused on the Quality Payment Program Quality Performance category. We'll be talking about the category overview, the different measure types, data collection and submission types, data completeness, scoring, benchmarks, a scoring example. We'll talk a little about the CMS web interface for those of you that are potentially using that as your submission method, and then definitely talking about measure specifications. It's really important to know how to identify patients that fall within the specific measures. We'll also get into questions and discussion at the end, and I have a bunch of resources for you. So, the quality performance category is the largest category currently of the MIPS 4 performance categories. It makes up 45% of the MIPS 4. This is all based on 2019 performance, since we're just about at the tail end of the 2018 data submission. We'll be focusing solely on 2019 for performance here. In order to receive the highest possible score, you would want to report on at least 6 quality measures. If you have more, you can definitely earn bonus points for those measures. In your 6, you'd want to make sure that you include at least one outcome or high priority measure. That's a requirement. And you can get, as I mentioned, bonus points for end-to-end reporting, which we'll talk about, additional outcome or high priority measures, as well as additional measures that look at patient experience. For the quality performance category, you do have to report on a full calendar year of data. That's looking at January 1st through December 31st of 2019. And then the quality performance category has this lovely component called data completeness, which we'll get into a little more. So it's really looking at how many patients you include in your data sample and whether or not you meet those requirements. So quality measure types, there's quite a few to choose from. And when you go in, I don't actually have a screenshot of it, but when you go into the CMS QPP website to the quality measure page, if you look at a specific measure, you can actually see what measure type it is. So it lists it right there. It'll say process or outcome or intermediate outcome. There's only a couple patient experience structure, definitely lots of high priorities that you can find. So what is a process measure? A process measure determines if the services have been provided to patients that are consistent and with routine care. So has that provider given all patients their flu shot? Simple measure, yes or no, they've received it or not. An outcome measure looks a lot more at, through that process, did you receive the result that was intended? So looking at amputation rates based on diabetes care. Obviously, you want to have a very low amputation rate to ensure that you're giving your diabetic patients the care necessary, getting those diabetic foot checks and whatnot. Intermediate outcomes are assessing a factor of short-term result that comes back to that long-term result of whatever that process was. So an example is, has the patient with hypertension had their blood pressure well controlled? Many of you are probably familiar with the blood pressure well controlled measure, looking at the systolic and diastolic blood pressure, that's a great example of an intermediate outcome. Efficiency measures, which again there aren't that many of, this looks at the variability in the cost of healthcare, and it directs efforts to make sure the cost is more affordable. So it's looking at diagnostic tests and procedures that are being ordered. Were they clinically necessary? Obviously, we want to try to limit the use of tests and diagnostic procedures that might not be necessary based on maybe other therapies a patient could get or other testing that could be done, or maybe it's just kind of that watch and see what happens case that we need to do with that specific patient. Not surprisingly, patient experiences, just as it says, is looking at the patient's experience to care and seeing how they would rate their communication with their provider potentially, or ability to access their electronic health record information on a portal or something to that effect. Structure measures, again, there's maybe 2 or 3 within the whole MIPS program. These look at the various characteristics within the care setting, so it's looking at facilities, personnel, policies related to that care delivery, and it's looking to say, okay, are there adequate resources in place to support whatever's going on? So the example is, are there adequate staff in the ED when there's an event going on in town? Hard to measure, kind of, but again, it's helpful to say, okay, if there's something going on, did we meet the needs based on whatever the structure of our practice was? As I mentioned, high priority might align with any of the process outcome, intermediate outcome, efficiency, or patient experience measures. It's looking mostly at whether or not those measures meet a specific element that CMS is considering to be a high priority. So a good example is the percentage of patients with acute bronchitis that were not dispensed an antibiotic prescription. Again, making sure that there's appropriate antibiotic use and looking at patients that might need that specific therapy. CMS has changed a couple things within the quality measure performance category in 2019. They've moved to something called collection types, which is really what type of measure are you looking at. So MIPS CQMs, or clinical quality measures, were previously those measures that were considered to be registry measures. ECQMs, which are the electronic clinical quality measures, are really those EHR-based measures, so whatever you're pulling right from your electronic health record. QCDR measures are just as they would seem. They're the clinical quality registry measures. Medicare Part B claim derived measures come right from Medicare Part B claims. For 2019, those are only allowed for small practices, so anyone in a practice of 15 or fewer eligible clinicians. Clinicians participating in an alternative payment model or in groups of greater than 25 who choose to use the CMS web interface, there's a whole separate set of measures that you would be reporting on under that group, and we'll talk about those more later. If you choose to use the CAPS-REMIT survey measures, those are again looking at patient experience. And then for any of you in a group of 16 or more who are eligible based on the number of encounters you have, might have the administrative claims-based measure. If there's only one, it's the all-cause readmission measure, which is pulled right from your claim. As I mentioned with the renaming, CMS is also looking at different data submission methods. So there's 4 different submission methods for the quality performance category. The first is direct. That's using an API. So that could be your EHR vendor submits data right through their process. You're using a registry, something to that effect, or it's a separate kind of portal, not the CMS portal. Then login and upload is using that CMS QPP portal, where you take either a QRDA3 file, or a MIPS file, or JSON file from your registry or EHR vendor and upload it right to the portal. And then the portal does a back-end algorithm check and pulls out the performance for each of the measures that you have data to support. If you choose to report, and again, you're in a small practice, you can use the Medicare Part B claims. You would want to make sure you have that quality code on all of your appropriate claims to identify patients either meeting or not meeting the different performance buckets of that measure. And then if you use the CMS web interface, very similar to the QPP portal, you would log in using your HARP account and upload the data based on the patient population that you have. All right, data completeness. This is a fun one. So, depending on the data submission method that you've chosen, so if you use Medicare Part D claims measures, you are expected to meet a 60% data completeness requirement. Now, that's looking at all of the applicable Medicare Part D eligible patients that meet that measure. So, at least 60% of those patients must be reported on in order to meet that data completeness requirement. If you don't meet that 60% requirement, you are capped at 1 point per measure. And we'll talk in just a few moments about how you get decile scores for each measure. But measures can earn up to 10 points. If you don't meet data completeness, you're capped at 1 point. So as you can see, if you have really high performance but don't meet data completeness, you're really making it challenging to get enough points to support high performance in this performance category. If you choose to report using the MIPS quality measures, clinical quality measures, the QCDR measures, or the ECQM measures, you also have that 60% data completeness requirement, but rather than just looking at Medicare Part D patients, you're now expected to report on all applicable patients. That's mostly because registries and EHRs and qualified clinical data registries, really the goal is to get all patients, not just patients based on specific payer. So that's why, again, you're not really expected to parse those out, but obviously claims, Medicare Part D claims are specific to Medicare Part D patients. If you choose to report through the CMS web interface, it's not quite called data completeness, but there are requirements on the number of patients you submit data for. CMS does an algorithm check and attributes patients to that, either as a large group if it's 25 or more clinicians, or the APM that's using the web interface. Based on the total patient population that's attributed to that group, then you have to report on at least 248 consecutive patients per measure, or if for some reason you don't get a full sample, you would have to report on all of those patients. So let's say in a specific measure you only have a sample of 100, you'd be expected to report on all 100. Each measure is given somewhere between 616 and 712, I believe it's somewhere around 700 patients, and you literally just go down. The consecutive is you just work down the list. You're not expected or you're not allowed to hop around and say, okay, this patient doesn't meet, this patient does meet. You can't really cherry pick your performance. You just have to go down the list. Patients might be excluded due to previous diagnoses. A patient might be deceased, and that might not be part of the measure specification. We'll talk about how you work through the specifications as well, but just make sure you check that if you're reporting through the web interface. Oh, I apologize. The screen got a little jumbled up. Anyway, for clinicians, I already mentioned this a little, but clinicians in small practices of 15 or fewer eligible clinicians, you are still able to use claims-based reporting, and you can use that either if you're reporting as an individual or as a group. Anyone in larger practices, 16 or more, whether you're reporting as an individual or a group, claims-based reporting is not an available option for 2019 and beyond. Also, clinicians in small practices will receive a 6-point bonus, which is applied to their quality performance category numerator based on being in a small practice. So they get a couple extra points there. I want to just touch on cross-cutting quality measures. So we hear this a lot. What are cross-cutting quality measures? CMS has a handful of measures. This is not by any means an extensive list or the exhaustive list of all of the cross-cutting measures, but just a handful to consider. And what cross-cutting measures are is they're really expected to be kind of applicable to all practice types. So whether you're an internal medicine provider, a family medicine provider, potentially a pediatrician, maybe you are a geriatrician, maybe you're a surgeon, maybe you are an endocrinologist. It could really relate to anybody's practice. So, and as you can see, I have the quality measure ID as well as the type of measure they all are. For the most part, they're all either high priority or intermediate outcome. There is a couple process in there, but again, it's expected to be sort of a general offering of measures that could potentially relate to anyone's practice. So the first is the advanced care planning measure. That's looking at making sure that all patients have advanced care planning documents or have refused that. Again, it's really important to make sure that patients have the documentation to say whatever their final health care wishes are if they're unable to make those decisions on their own. That is a high priority measure. Preventative care and screening for BMI, that's screening and follow-up. So if a patient comes in, whether their BMI is either above normal or below normal, you're expected to give them follow-up, maybe it's diet counseling or exercise counseling, either way. That is a process measure, really important to make sure that patients maintain an appropriate weight. The next high priority measure is documentation of current medications in the medical record. So that is just as it sounds, that is reconciling the medications to make sure the patient is taking what they say they're taking, they understand their medications. You don't necessarily have to go back and do a lot of education and document that, but you need to at least go through and notate that you have reconciled the medications and they are current and accurate. The next is the preventative care and screening, tobacco use and cessation intervention. This is a process measure. So this is, again, kind of a two-part measure, looking at patients that are current tobacco users and offering them cessation intervention. That could either be referring them to a Quit Works program if you have that in your state, or offering them medication-assisted therapies if appropriate, or doing other cessation counseling. And it's usually more than 3 minutes of counseling will apply to that cessation intervention. As I mentioned back when we talked about the first intermediate outcome type measure, controlling high blood pressure, this is an intermediate outcome. This is looking at patients that do have hypertension, making sure they have a blood pressure of below 140/90. And then finally, the preventive care screening. This is screening for high blood pressure and follow-up. Again, that's looking at those patients that potentially have higher than normal blood pressure, providing them with a follow-up plan to get that blood pressure under the expected norms. And that is a process measure as well. All right, now comes the fun part, scoring. And this is going to get kind of heavy, so please ask questions. As Morgan mentioned, you're more than welcome to ask them in the chat. There will be time at the end to ask more questions, but this can get really complicated, so I'm going to try to make it as simple as possible, so hopefully answers any questions you might have. So, for 2019, the quality measure scoring for this performance category, you earned 45 MIPS points for the performance category. Your score is calculated by the total number of points that you earn for the measures you select, plus any bonus points you earn over the total points possible. So for most of you, that will be 60 points because you get 10 points, potential of 10 points per measure, and you would report on up to 6. Now, there's an additional component in 2019 that includes improvement scoring. So if you have an improvement in your score from previous years of performing, which would be 2017 is really what they're looking at, CMS will do a review of all of your performance and then give you an improvement score. We haven't yet seen how the improvement scores play out, so I can't tell you exactly how we expect to see that, but you do have the potential for an improvement score. So, total points earned plus bonus points over points possible plus any improvement score equals your final quality score. And we'll talk about what that actually looks like once we get a little farther along. So let's talk about a breakdown in the exact score. So as I mentioned, each measure has a decile performance score, and that ranges between 3 points and 10 points per measure. And you earn whatever score possible based on historical data that CMS has pulled on each of those measures to identify whatever that performance is. If you report on additional high priority outcome or patient experience measures, you can get 2 points per outcome or patient experience measure and 1 point per additional high priority measure. Again, it's dependent on how many you report on, so on and so forth. You can get an additional point per end-to-end reported measure. So this is looking at your electronic health records. Do you pull measures right from that? Are you using the QRDA3 file or JSON file or XML format to pull those measures, and then you get an additional bonus point for each of those. I would also like to add, in 2019, you do have the option of reporting your quality measure performance via multiple submission methods. So let's say you have 4 measures that you want to pull from your EHR. You'll get 4 bonus points there, but then you take 2 measures, if you're in a small practice, let's say, from claims data. You could have those 2 measures. CMS will take really the best possible score of the 6 highest measures that you submit, and then additional bonus points based on whatever else you might submit. So, this is the lovely, I've removed a couple of the columns, but this is basically what the benchmark document looks like for 2019 performance. This is available right on the CMS, the ppp.cms.gov website. You go under the resources and then quality measure benchmarks. And as you can see at the top, there is the measure name on the far left, the measure ID. This is all of the quality IDs. the submission method that's chosen, and we'll talk about that in a moment, the measure type, if there's a benchmark, and that becomes important in just a minute, and then each of the deciles, what the performance is for each of those deciles, and whether or not the measure is topped out. And as you can see by the medication reconciliation post-discharge, this measure is in fact topped out because you have to have nearly perfect performance in order to get even just 3 points. So it's really important to know what measure you're selecting, what the performance is to get you as many points as possible, and then how you plan to report. So let's talk about the diabetes hemoglobin A1C for control measure, the very first 3 rows of data. If you look at this column, so the column that shows you the submission method, you'll see the first option is for EHR reporting, then claims, and then registry or QCDR. So let's assume for a moment that we're going to report using our electronic health record, and we have performance of an even 14%. So if we were using our EHR, and we had 14% performance, we would come out right kind of at the bottom of decile 10. So we'd get maybe 10.1 points for that one. Now, if we chose to report claims, we would do a little less. So we would end up kind of on the high end of decile 6. So maybe we'd end up with right around 6.8, 6.9 points. And then if we chose to use registry or QCDR, we'd end up somewhere right in the middle of decile 7. Or maybe kind of towards the low end of decile 7, so like 7.2, 7.3 points. So as you can see from this example, which is just one measure, there's a tremendous variation in how your performance will earn you different decile points, which turn out to be the points you earn for the entire performance category. So from this one example, you might think, wow, okay, EHR seems like the best way for me to report. However, as I mentioned, and now in 2019, you can report multiple different methods. Previously under MIPS, you could only submit data via one method. So the measures you want to report on might even not be available for EHR. As you can see from medication reconciliation post-discharge, the only 2 submission options are claims or registry. And for fall screening, for future fall risk, that is only available for EHR reporting. So it's really important to go through the benchmarks, see what the performance is that would get you the highest number of points, or see kind of where your current performance is, or maybe where your historical performance has been, and identify what your goal is. Are you planning to use a certain method, and it's only that method, and then based on your performance you'll earn points, or are you really looking to maximize your points, and your method of data submission will vary based on that need. So I'm going to just go through a couple measures, 6 measures, and then I'll show you how they all score out. So first measure that this group, actually it's going to be a fictitious group, chose to report on was the diabetes hemoglobin A1C for control measure. Their performance is 22.2%. That would get them into decile 8, which this is the performance range, 25.87 to 20.56. This measure, just by the way, is an inverse measure, so you actually want to have lower performance to get a higher score. The average performance on this measure is 46.3. The next measure they've chosen, and by the way, that's the outcome measure that they're going to be reporting on. The next measure is the pneumococcal vaccination status for older adults. Their performance is 55.3%. That would get them into decile 6, which is 53.44 to 62.85, kind of on the lower end of that decile, and the average is 50.8. The next measure is the controlling high blood pressure measure. They have a performance of 72.6 points. That gets them into decile 8, which has an average of 72.01 to 76.2, and the measure average is 63 points even. Next, they have use of high-risk medications in the elderly with a performance rate of 13.8. That gets them into decile 3 with 8.04 to 4.75%, and the average is 4.7. The next measure is depression utilization of the PHQ-9 tool. Not high performance here, only at 7.4%. That gets them to decile 4, 6.2 to 9.08, and the average is 18.6. Just as a quick note on this one, you can see that some of their performance isn't all that high, but in the end, you'll see they actually do end up earning quite a few MIPS points towards their final MIPS score in this performance category. The final measure is closing the referral loop. Receipt of specialist report. They had 41.1% performance, which gets them into decile 6, and that's 36.74 to 48.14, and their average is 41.2. So if we put all of that into a lovely table, I have all of the measures they selected, sorry, they're not in exactly the same order, and then their performance. They did select using their electronic health records, so they're going to be getting 1 additional bonus point for every measure. They're also going to be getting some bonus points for reporting on additional outcome and additional high priority measures. So they get 2 additional points for 2 high priority measures and 2 points for 1 additional outcome measure. As you can see, that gives them a total of 6 bonus points. So the 6 from EHR plus the 4 from the additional bonus measures gives them 10 points. Their overall performance came out to 35.6 points based on the score and the deciles. You kind of have to guess here a little because it's not 100% based on where they fall in that decile range. But that got them 35.6 performance points. So adding the 2 together, they come out at 45.6 points over a total possible 60. So 45.6 over 60 brings you to 0.6. And then you would multiply that by the total weight of the performance category, which is 45 points, brings them to a grand total of 34.2 MIPS points. So while they're not maximizing the total 45 points available for this category, they're getting pretty close to it with 34.2 points. And as many of you might remember, in program year 2019, the MIPS performance point threshold in order to avoid a payment penalty is 30 points. So they'd easily surpass that 30 points and would avoid a penalty just in this one performance category. Now there's 3 more that they can report on and earn additional performance points. And there is their score. So you might be saying, okay, that's great. Why does the benchmark matter? It seems really complex. So historical benchmarks are pulled from actual data that was submitted by all of you and other clinicians across the country in 2017. And then CMS identifies where the average performance is and how they want to identify the various deciles based on that performance. The important thing about the benchmark is that's really what gives you that 3 to 10 points. If there's a benchmark for a measure, you will earn somewhere between 3 and 10 points. Now, not all measures have benchmarks. Sometimes benchmarks are not available because it's a new measure or not a lot of clinicians have reported on it. So CMS doesn't have an adequate sample to say, okay, this measure has historically earned this performance, and we think that this decile should go with this performance rate. So if you happen to pick a measure that doesn't have a benchmark, don't fret. That doesn't mean you're not going to get any points. If there's no benchmark available, then the measure will only receive 3 points. However, if CMS is able to calculate that benchmark, you can earn additional points. So if there's no benchmark and you can't calculate it, then you don't get more than 3 points. If CMS can calculate a benchmark, I apologize, I think actually there's some bad wording in there. But if they can calculate a benchmark, you would go off whatever that benchmark that's identified as and the appropriate decile scoring. You must still meet data completeness and case minimums. Case minimums usually are right around 20 measures. That's the sample that basically says this is an adequate sample of patients, and we can then take performance and identify whatever the benchmark should be. Now, this is one of my most favorite parts of the whole presentation. I love measure specification sheets. I think that they give us such a wealth of information, but they can get really complicated really fast. And so if you're looking at this right now thinking, whoa, what is she going to be telling me about? Don't worry, we'll go through it. So this is the measure specification sheet. I just picked a random one for the primary open-angle glaucoma measure, optic nerve evaluation. It is quality ID 12, and it's an NQF supported measure. So really what you want to look at is there's a lot of information about the measure type. This is a process measure, the MIPS, CQM, so it's a registry measure, a little bit of the description, so patient age, they have to have glaucoma, the instructions, kind of talks about how you work through the workflow potentially or the process, and then the measure submission type, talks a little bit more about the different components there, and then you'll see denominator, and I apologize, it's kind of small. And this is really what you want to focus on. So for the denominator of this measure, it says all patients aged 18 and older with a diagnosis of primary open-angle glaucoma. So that's the first bucket. So anyone that falls into that bucket is potentially part of your denominator. Next, you have to start whittling that down because not everyone that falls into that bucket is applicable for this measure. So then you have to go to the denominator criteria. And these are all the eligible cases. So once you look at all of your patients age 18 and older who have primary open-angle glaucoma, you'd want to say, okay, did that patient greater than 18 years of age have an encounter during my reporting period? And so that would be the full calendar year of 2019, so somewhere between January 1st and December 31st. If you can say yes to that, you'd move to the next category. And then you look again at that diagnosis. And so there's a whole list of the various ICD-10 codes that apply. I'm not going to read them out. You can see them here if it's applicable to your practice. Awesome. You can run with that. If not, just keep that in mind as you start looking at all of the other measure specification sheets. They follow the same flow. So type of encounter, type of diagnosis code, and then the next piece is really critical, is looking at the specific encounter code, so that CPT code or HCPCS code, potentially, depending on what kind of code it's looking at and type of patient. Did that patient have one of these encounter types? And based on this, it's mostly the generic E&M code, so it's 92002, 92004, let's go a little further, 99214, 99212. Those are some pretty basic in-office evaluation visits. Did they have one of those? Yep, check. And that wasn't a telehealth modifier. So if the patient was seen via telehealth and they have these various modifiers, then they can't be included in this measure. So as long as you can say yes, 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 no, then great, you'd move on. We find a lot that is this encounter code section with the CPTs performed during the performance period that really is one of the most limiting factors to whether or not our clinicians can report on specific measures. Certain practice types, we see this oftentimes with clinicians going into the skilled nursing facilities. They have very specific E&M codes they report on, and they might think, okay, great, I'm going to report on, I'm just picking a random measure, influenza immunizations. However, let's say that influenza immunization doesn't allow for the specific encounter codes they charge or bill to, they would not be able to select that measure because that patient wouldn't meet the requirement. So that gives us our denominator. Next, we want to move on to the numerator. So who falls into our population? So as you can see here, the numerator is made up of patients who have an optic nerve head evaluation during one or more office visits within 12 months. So you look at the numerator, exclusions or exceptions, based on the date of the denominator with the eligible encounter. So there's a couple of components. This gives you some nice claims codes. So this is actually a registry measure, but it also gives you the claim code if you're planning on using claims. So from here, you would say, okay, do my patients meet any of these three elements? So the first is performance is met. So the optic nerve head evaluation was performed, and there's documentation of the charge 2027F. Or was the denominator exception met? And this is documentation of medical reason for not performing that optic nerve head evaluation. Not sure what that might be, but if the patient fell into that criteria, you'd want to make sure that you have documentation of 2027F with that 1P modifier. That means the patient was in the exemption bucket and they fell out of your numerator population. Or did the patient just not have the test performed as it should have been, and that would be optic nerve head evaluation was not performed, and the reason is otherwise not specified. There's no contraindication, allergy, medical emergency that occurred, whatever the case might be, and that would be 2027F with the 8P modifier. So kind of work through the process. Did they need it? Yes, great, they would have this code. Were they exempt for whatever reason? Yes, they have this code. Or did they just not have it met because it wasn't done for whatever reason, then they would have this code. So it's pretty simple, but it's really important to make sure you work through the whole process. And this is a really nice algorithm. If you go into any of the CMS quality measure specification sheets and kind of scroll almost all the way to the bottom, they do this nice kind of Visio layout. It's really hard to read, so don't worry about it. But it's basically everything I just worked through with you. So you start, you have the patients that are of the appropriate age on the date of the encounter. If yes, then you would move down. Do they have the appropriate diagnosis? If yes, you continue moving down. Was the encounter during your performance period? If yes, Great. Did you have the telehealth modifier? No. Great. They're in your denominator. If you said no to the age, or no to the diagnosis, or no to the encounter, then they fall out of your population. And if you said yes to that telehealth as we worked through, then again, they fall out of your population. Once you have that denominator group in the white box at the bottom, you move on to that numerator. So, was it completed? Yes. Then you move on and they become the green population, which is in your numerator population. If it was no, then was there a reason why not? If that was documented, then you move on and they are excluded. And if no, and there's no reason, then they would come into your not met bucket. And for whatever reason, you would also have any other group that might not have had it met for, it wasn't documented. At the bottom, there's some information about that data completeness. So it gives you the total. If you blow up this example, there's actually numbers of patients. CMS gives you a tally. So you end up with, I can't read it. 80 patients. There we go. 80 patients in your denominator. You have 40 patients in your true numerator. 10 patients are excluded, and 20 patients didn't meet. And there are 10 patients that did not have data completeness met for whatever reason. So that gives you your total data completeness percentage. They end up with, I think it's 82.5%, so they're over that 60%. But you can kind of figure out how you would perform that way. Like I said, a wealth of information on the measure specification sheet. Really great to work through the process as well. If you're not sure, does my practice have the right process in place? Are we capturing the data the right way? You can work through this and make sure, okay, maybe your rooming staff needs to do something a little differently, or maybe your providers need to do something a little differently, or maybe the checkup staff needs to do something a little differently. Really helpful in identifying, okay, here's the set, here's how we're collecting our data, here's how we're performing. It either lines up or it doesn't. This is just an example of what the electronic clinical quality measures, the EQQMs, look like. Slightly different, not quite as pretty as the other either claims-based or registry measures, but again, basically the same information. This actually isn't the same measure. It's for the one of the depression measures. So you can see in the initial population, new or recurrent major depressive disorder encounter. Then we have the calendar year, so it's looking at their birth date during the measurement period. They have to be over 17. The denominator is that total initial population. There are no exclusions for this one. And then the numerator is newer recurrent major depressive disorder encounter. And then they have an intervention performed, so they have the suicide risk assessment completed, and documentation of that was included in the chart. There are no numerator exclusions, no denominator exceptions, and no stratifications. You can kind of find out where that population might be. And again, this is just giving you a little more information. Again, we always need to make sure we're looking at those specific encounters. So for this example, the encounters look at a psych visit, diagnostic evaluation, emergency department visit, office visit, outpatient consultation, psych visit, psychotherapy, psychoanalysis, and that's all they include there. So just make sure you're including all of the appropriate encounters and making sure that you're documenting based on whatever kind of encounter your clinicians are having. And again, it looks at the various days. There's all different requirements based on the measure, how many days in the past, how many days in the future, total encounter time, lots of little bits and pieces of data to consider there. Okay, just briefly, I want to touch on facility-based scoring. So this is for clinicians that furnish at least 75% of their covered professional services at place of service, 21, which is the inpatient hospital, 22, on-campus outpatient hospital, or 23, which is the emergency department. You have to have at least one service billed in place of service 21 or 23 to be eligible, and the hospital that you're affiliated with has to have performance data for the value-based purchasing program. So if your hospital hasn't participated in the VBP program, unfortunately you can't take advantage of this option. It is a really great option for clinicians that are considered to be facility-based, only those hospital-based clinicians. The CMS will automatically give you a score based on your performance or your organization's previous performance in the value-based purchasing program, and then that automatically gets applied to your quality and cost performance. Now, you don't have to use that as your performance. CMS will take whatever the better of is. So value-based purchasing for the hospital will automatically be applied if you are a facility-based clinician. However, if you choose to report quality measures on your own, and let's say your performance is significantly better or only a point better, whatever it is, but better than the facility-based scoring, then CMS would take your submission of data. So it's whichever comes out better. If you are struggling to identify measures or have an issue with your electronic health record or whatever the case is, and you just want to go the facility-based route, you can absolutely just take those measures. You don't have to submit any additional data. It's automatically pulled from the hospital value-based purchasing performance. All right, APM. So, if you are participating in an alternative payment model, a couple things to consider. So the APM score for the quality performance category is 50% of the APM's total performance. So it's a pretty big chunk. All APMs use the CMS web interface. That is the method of data submission that is utilized by all the APMs. Benchmark. So unlike or kind of similar to the benchmarks we just went over, CMS uses the benchmarks for the Medicare Shared Savings Program. And these benchmarks go off of like decile 1, 2, 3, and it's usually just a 10-point spread. So decile 1 would be 0 to 10% performance, decile 2 would be 10.1% performance to, I guess, 20%, and so on and so forth, up to 10, which would get you to 100% performance. Unlike the Medicare Shared Savings Program, MIPS caps performance, the lowest you possibly get, based on whatever your performance is 3 points, and that's at the third decile. So everything with the web interface is backtracked, so the lowest you would get is that third decile. So anything below whatever the third decile performance is gets kind of rounded up, and you get that third decile performance. So you do, in fact, do a little better. It is just like the rest of the quality performance category, a full calendar year of data, and as I mentioned with the attributed patients, you're reporting on all data for those attributed patients in the various samples that you get for each quality measure. The quality measures for the web interface are similar but slightly different than the general MIPS measures. CMS has actually reduced the number of required measures. You would now be reporting on the fall screening for future falls, preventative care and screening for influenza immunization, preventative care and screening for tobacco use and cessation intervention. These should look pretty familiar to what we just talked about. Preventive care and screening for depression and follow-up, colorectal cancer screening, breast cancer screening, statin therapy for the prevention and treatment of cardiovascular disease, depression remission at 12 months, diabetes, hemoglobin A1C poor control, and the hypertension controlling high blood pressure. CMS is no longer giving additional bonus points for additional high priority measures under the CMS web interface because, again, you're required to report on all of these measures and it's kind of seen as your bucket of performance. So, unfortunately, no additional bonus points are available in the 2019 performance year. And that brings me to the end. If you have any questions and would like to ask them over the phone, it's pound 6. If you would like to ask them in the chat, you are more than welcome to. While I wait for questions, I'm going to jump ahead just one slide to give you my contact information. If you would rather send questions directly to me, you're more than welcome to do that. And I will now hang on the line, and if you have any questions, please feel free to ask. So I see a question from Suzanne. Are there the same benchmarks used for ACO measures in the quality performance category? No, they are not the same, Suzanne. They go off of the benchmarks for quality under the ACO measures, look at the Medicare Shared Savings historical benchmarks, which are also available. I apologize, I don't have the link. If my team is on, maybe you could pull that right from the QPP website, but that is all available in the qpp.cms.gov website. But again, it's not exactly the same measures because they're not quite the same populations being reported on, but they're very similar. Again, please feel free to ask questions over the phone at pound 6 or in the chat. Oh, great question, David. So David just asked, how do I find out if my organization has a hospital DVP program total performance score? Excellent, excellent question. So if you currently have access to the CMS QPP portal, where you would use your HARP account as previously the EIDM account, if you can go into that portal, you can actually see on the left-hand side, there's a whole bunch of little buttons. One of them says, facility-based scoring preview. You can actually see your score for this year if it's not available yet, but you can at least get a preview to see what your previous performance might have been. You'd also want to make sure that whatever clinicians you're looking at are designated as either hospital-based or facility-based. It is available on the participation lookup tool, which is also available on that qpp.cms.gov website. You would enter their NPI, and you can kind of go through and find out. If you're not sure, if that seems really complicated, I'm more than happy to help you with that. Just feel free to shoot me an email, and we can set up some time and walk through it together. Another question, will the complex patient bonus also apply as well as the readmission measure? Yeah, great question, Suzanne. I did not include much about the complex patient bonus, but that is certainly part of it. That's not specifically related to the quality performance. That's kind of a general overarching component to the MIPS program, getting that complex patient bonus. So yes, that's still 100% applicable if you have complex patients, of course. And the readmission measure, that comes in if you have a group of greater than 16 eligible clinicians reporting together, and you have a case volume of more than 200. So depending on how big your group is and how many Medicare patients you see and so on and so forth, that might come into play and it might not. But if you're a large group, I would just say kind of assume that you'll have the readmission measure, but it's all dependent on those couple elements. Thank you to my colleague Tushar. She just gave me the link to the MSSP benchmarks. So here are the benchmarks for you if you're looking for how the CMS Web Interface benchmarks will be calculated. You can look at this document. It is very helpful. But again, they kind of fall into this weird like 10 points per decile. But again, CMS kind of bumps them up if you're in the 1-2 decile. You move up to the third just to get 3 points. While we're waiting for additional questions, I'm going to jump one slide ahead. We have a whole bunch of resources. We have our New England QIN-QIO macro page, which has lots of information. We've actually just updated a number of different resources for the 2019 performance year, as well as included information for the new eligible clinician types. If you'd like to ask a question there, you're more than welcome to ask your question there as well. Here's also a link to the qpp.cms.gov website. Again, lots of information on the various components of the program. CMS has done a really nice job this year. They kind of did an overhaul to the resources page where there's lots of filtering capability. So you can go through and say, I want to look just at quality and just at this year and just at this type of participation, whether it's MIPS or APM. Also a link to the participation lookup tool that I just referenced, as well as the portal. So if you have any questions, please check out the QPP website. It's great. If you are still unsure, we are here to help. We want to make sure that you are successful in your QPP reporting. And just a shameless plug, if you haven't yet submit data for 2018, you have, today is 26th, 7 days. You have exactly 7 days left. All of your data has to be submitted to CMS by April 2nd at 8 p.m. If you are reporting through the web interface, well, I certainly hope you have submitted your data already because the window closed on March 22nd. But if you have any questions, please don't hesitate. We want to make sure you're all successful and don't get a MIPS penalty, so please reach out.
Leila, while we wait for some more questions to come in, I'd like to just go over the closing messages. As a reminder, we are on social media, so visit us on Facebook, LinkedIn, Twitter, and YouTube. As you close out of this webinar, the evaluation will automatically pop up on your screen. So if you can please fill that out, we would greatly appreciate it. If you don't have time to fill it out right now or you're sharing a computer with somebody, you will receive an email tomorrow with a link to the evaluation as well as a link to the event webpage where you can find the PowerPoint presentation. And within the next few business days, we'll also be adding a recording and transcript of the webinar as well. So thank you again, and we'll stay on for a few more minutes while we wait for questions.
Thanks, Morgan. So yeah, as Morgan mentioned, we'll be on the line. I'll stay on line until about 12, and feel free to ask your question over the phone, #6, or in the chat. And if you have questions about 2018, happy to field those as well. I know we talked about 2019 mostly today, but really any question is open. For those of you still online, if you have any remaining questions, feel free to ask them over the chat or on the phone line, #6 is the number. All right, well, we're just at 12 o'clock, and I thank you all that are still on the line for participating today. And if you have any questions, please don't hesitate to reach out. We want to make sure you're successful. And again, thank you, and have a wonderful rest of the day. Take care.
Conference will be terminated in 5 minutes.